I'm Morgan Price. I'm a family doctor and one of the interim co-heads in the Department of Family Practice. And before I introduce our speaker, I'm going to just tell a very brief story. When I was about 6, I lived in Toronto, and somebody came to the door, knocked on the door and asked to see my father. And I tried to close the door on him because I didn't want any insurance salesman in the house. I'd assumed he was an insurance salesman. And it turned out it was actually my long-lost brother. My long-lost brother is David Price, who is no relation to this David Price who I'm about to introduce from McMaster. He's a chair over there and a family doctor, and he's come to talk to us about earthquakes and liquefaction zones and primary care. Come on over, David.
Yeah, Morgan and I often have to do that. We're not related comment. Okay, well, thanks very much, and thanks for having me. And I'm going to do this for about 30 minutes. Hopefully, we'll have a little time for a chat afterwards. So, you know, when you travel, and is there a reason why that keeps going beep beep? It's just people joining in, so I don't need to worry. Okay. Yeah, fair enough. So when you travel and somebody says, "Where are you from?" I always have to say, well, actually, I'm from Vancouver, but I now live in Hamilton. And for those of you who know Hamilton, this is probably what your image is of Hamilton. Or if you've driven over the Skyway Bridge from Toronto to Niagara Falls, this is what your view of Hamilton is, or your memory of Hamilton. It's a very much an industrial city, which probably had its heyday in the early 1900s in the time of steel. But, you know, I took this picture from what we call the high-level bridge, and if you move the camera just a couple of degrees, you have that kind of image of Hamilton. And if you move it literally only another 2 or 3 degrees, and if I showed you that one, you'd have a very, very different view of Hamilton. And I think that's what the message I'd like you to think about as I go through this presentation about primary care and what maybe has to shift, and it's not a huge shift you have to think about over time. And I'll just acknowledge that we are on the traditional lands of the Musqueam, and while I'm not going to address the First Nations issues per se over the course of this lecture, it's one of my planks in terms of what I've been dealing with at McMaster as one of the priorities for us and our department in thinking about the Truth and Reconciliation recommendations and understanding our relationship with our First Nations neighbors. So how are we doing in primary care in Canada? And I think all of us would agree there's a number of different ways to look at that. And what I've put up on this slide is health expenditure versus life expectancy. And this slide's almost 10 years old now, but I did just a quick review, and it really hasn't changed. And we do very well in this country in terms of our life expectancy. And you can see that Canada is up near the top. It's up near the top with the Nordic regions, Norway, Sweden, Finland, Denmark, etc. And the only slight difference is that we spend a little bit more money per capita than they do. But of course, Canada's a big country, and it's not that simple. And if you look to further along, you can see Yukon with about $4,000 expenditure and a slightly lower life expectancy. And then if you go right to the very far right of the screen, you can see Nunavut, which has a life expectancy that's maybe 10 years lower. And we spend a considerable amount more money in that environment than we do Canada overall. And a lot of this, of course, has to do with social determinants of health. And probably we could get rid of pretty much all of the medical system in this country, and we'd still score pretty well because of our health care writ large, our public health policies, our social safety nets, and so on. So geography clearly matters, and distance clearly makes a difference in terms of our our health care and our health care expenditures. But it matters also at the urban and at the local level. So about 10 years ago, 2000, or 8 years ago, 2010, the Hamilton Spectator did a series looking at life expectancy on the various postal codes. And in downtown Hamilton, in the north end of Hamilton, versus literally less than 2 kilometers away, there was a 20-year life expectancy difference. And I'm sure that would be the same if we explored in the downtown east side here, if we go to some of our marginalized communities. So it's clear that it's not just a geography problem, it's a social problem in our communities. And I think this has relevance for us in terms of how we think about primary care and our primary care policies as we move forward. There's other ways of looking at our primary care system, and when we compare ourselves against the OECD countries with the Commonwealth Fund, the important thing to this busy slide is if you just look at Canada on the left-hand side of your screen, and if you compare how we look against all of our comparators, we score at number 10 or 11 every single time. So we're doing not so well overall when we compare ourselves. And at the same time, we're spending a considerable amount, well, we're spending somewhat more than many of our OECD comparators. And the States is the group that we always say, well, we're doing quite well. We're better than the United States. And we have to remember, U.S. is 350 million people, and 200 million of those 350 million people receive outstanding primary care and would probably rank in the number 1 on most of these indicators. When you think about what Kaiser Permanente is doing with the Veterans Affairs and a number of their HMOs, they actually do provide really outstanding care. The challenge with the U.S., of course, is the discrepancy is really large. And there's many different things the way they've looked at it, and I'm going to come back to this, but it's important to note that when we look at some of our comparators, to be able to see after hours, to access after hours care, it's probably around half of our patients can do so. We're abysmal in terms of our use of technology, and this is something that there's all kinds of metrics that we've looked at in terms of our ability to use technology in this country, and it really lacks or lags our comparators in developed nations. But we're also seeing, of course, a demographic shift, and this year was a seminal year for the first time in Canada. We have a higher proportion of older folks over 65 than we do under 14, and this is a complete shift, and we have to remember that this changes how we approach healthcare and how we approach primary care, and this graph apparently will continue to change as we move forward, with the exception, of course, of some communities, particularly our First Nations communities, where there's still a much larger proportion of younger folks. So if we're going to say that we have a higher incident or higher ratio of older, how are we doing with our care of the elderly? And so this is results from the Commonwealth Fund's 2017 survey of seniors. And I can tell you in a word, we're doing about as well as we are in the overall primary care. We're not doing well at all. I'm going to pick on BC just because we're in Vancouver and in British Columbia right now, and look at some of the results from British Columbia in comparison. And if you look at seniors who say they're receiving good or excellent care over the last 12 months, BC rates at about 64%, Canada at 67%, significantly below our OECD average. And that's just an overall snapshot. If you look at access, and this is a key component in everything, and you can see that these orange bars on this graph represent below average on almost every single metric in every single Canadian province. We rank poorly. And we rank substantially below the Commonwealth average on almost all of these indicators in terms of access. So we clearly have a long way to go in terms of thinking about how we create our system. And this was, you may not be able to read it, but being able to see a doctor the same day, it's somewhat easy to get care in the evening. And notice that they said somewhat easy, not that it is easy. They even modified it to say somewhat easy, and that they're able to get an answer the same day when they contact their doctor's office. But it's not necessarily about individual physicians, and the take-home message from this slide is patients' experience with their regular doctor. We actually, in Canada, score reasonably well. And I think what this demonstrates is that individual physicians and primary health care providers are generally well liked by their patients. The patients generally think that his or her family physician is doing a reasonably good job. I think what this indicates is that hardworking family docs within the system are not able to provide system-level care. So we do a great job looking after our own patients, but our challenge is that we're working within a system that hasn't evolved to meet population needs. Now, what about those healthcare providers? If we say that they're working pretty hard and doing a generally a good job, what are their challenges? I mean, the first is the explosion of knowledge, right? And this is from a JAMA article in 2001, which suggests that we should all be reading about 20 articles a day. So I don't know about the rest of you, but I'm now this week 39 articles behind. And for this year, I'm probably somewhere around 400 articles behind. So, I mean, this is clearly a challenge. And this is a huge shift, isn't it? And I thought, I graduated in 1987, just looking at diabetes. And in those days, there was two types of insulin. There was R and there was N, regular and NPH, right? There was 3 or 4 oral hypoglycemics. Just a quick literature search, I was able to find 15 different types of insulin, and that doesn't even include the combination insulins. And again, the number of oral hypoglycemics is more than 10, and again, there's huge numbers of combinations. So the point here is, 30 years ago, it wasn't impossible to be able to manage as a primary care physician diabetes on your own de novo. It has gotten incrementally more complicated, and we have to remember that. And if it's more complicated in diabetes, it's also in COPD and cholesterol and heart failure and kidney failure, et cetera. So clearly, as family physicians and primary care providers, our world and our landscape has changed. This slide is from Dr. Dee Mangan, who is our research chair, David Braley, Nancy Gordon research chair in family medicine at MAC. And I challenged her on this, and I said, are you, really? The average 45-year-old Canadian is on 4 medications? And she assures me that that is actually, from a system-wide, true. And the other stat, which I thought was quite something, is if you're over 65 and you're on 1 medication, you are likely to be on 7. So our complexity has skyrocketed. And if you think back 30 years, for those of you who have been in practice for 30 years, well, that's just me. So the rest of you haven't been in practice 30 years. But for me anyway, my patients weren't on 7 or 8 medications 30 years ago. They were on a couple. And typically if you're in your 80s and you're healthy, you're on no medications, right, in those days. Now it's multiple morbidities that we're living with. The good news is we are all getting older, or at least this present company accepted. We are getting older, and the millennials have a different way of thinking and a different way of approaching. It was interesting, one of the millennials said to me today that even she is feeling like she's getting behind the technology because her younger siblings have such a greater facility. Imagine what it's like for those of us who are in our 50s. And so I think this has a message in terms of how healthcare is going to evolve. And so our folks are changing. And so if we've said that our primary care system isn't working very well, and that our patients are changing, the demographics are changing, our knowledge is exploding, what is happening with our system? Our system, of course, in primary care hasn't changed a whole heck of a lot since the late 1800s. And what was it in the late 1800s? It was a solo family physician working by his, or it was mostly his self. There were some women, obviously. But that really hasn't changed all that much. And in those days, a solo family physician could manage most conditions that presented in his or her office, and the little small rowboat was good enough. That clearly doesn't work anymore, and we're going to need to be thinking about how our system evolves. And if you look at around the globe, we have definitely moved from a fee-for-service, transactional-based system. Most countries have moved towards the value-based system. And the ultimate, of course, is to get to a system where we pay for outcomes. Probably not going to happen in our lifetimes, but that's where people are moving towards, is some sort of salaried, blended capitation kind of model and sort of bundled payments. And if you look at the high-performing models around the world, most of them are value-based. Whether you're in capitation, Italy, UK, the Netherlands, Norway, for example. And there are some high-functioning areas that are still on fee-for-service, but those that are on fee-for-service tend to be in a bundled model. They aren't strictly transactionally based fee-for-service models. We also, across Canada, are now once again experiencing a family physician shortage. So I'm doing some work in Nova Scotia. The stat that really hammered home to me is that in Dartmouth, which is kind of like Surrey compared to Halifax, or Surrey compared to Vancouver, Dartmouth to Halifax, 40% of the physicians are over age 55 and are expected to retire within the next 5 years. Quebec has a doctor shortage. A family physician shortage. But in fact, their models have actually evolved in spite of the fact that they have a net exodus of physicians. Their family physician shortage, in particular outside the major urban centers, isn't too bad. They've managed to create the kind of models that have supported physicians in their more rural areas. Ontario actually does not have a family physician shortage. We have a distribution challenge, but we have an excess of family physicians in the GTA, the Greater Toronto Area, which is 5.5, 6 million people, and yet we have an excess. And in fact, we have family doctors who aren't able to get enough patients to make a living in the GTA and are having to move elsewhere. And why is that? I'll talk about this later. I think a lot of it is because the evolution of our primary care models. We are attracting young people to work in the models in Ontario. Alberta's solution to everything in medicine is to pay more, and it's worked. But it's worked temporarily. They are now moving towards primary care networks. They are having a similar sort of challenge with some of the younger folks and in some of the rural and urban areas in terms of that their model hasn't kept up with what. And of course, if we move to British Columbia, I love British Columbia because you still love hyperbole out here. So this is from December of this past year. The prognosis is bleak for those British Columbians amid the province's doctor drought. I mean, it's really the end of the world, isn't it? And doctor shortage putting pressure on small town ERs. Again, it's from what my reading is there's a bit of a distribution challenge that you have in British Columbia, and you also have a similar problem to what we're having in Ontario and other provinces, whereby younger graduates are choosing subspecialty type work, whether that's in a hospitalist, whether it's in sports medicine, wanting to go into palliative care, etc. One of our challenges in the GTA is because we have a family doctor excess, many of our recent graduates are moving into boutique practices, and if they can get it, they're going into the cosmetics and all the other things, and it seems like counterintuitive to spend all this money training our graduates so that they can go into sort of private medicine. So I think it's clear that moving to evolving our models, and our younger folks are clearly driving this. And I'll just leave you with this thought. I attended all 4 of those births, but only 2 of them are mine. Ontario, in 2002, most of us were in a fee-for-service model. It's now more than 80% are in some sort of primary care model. And I say some sort because about 45% are in some sort of salaried blended capitation model. Those that are still doing fee-for-service are in a comprehensive fee-for-service group. We call them FIGs, family health groups, where they get extra incentives and money for providing comprehensive continuous care, even though they're doing it in a fee-for-service environment. We are moving rapidly away from fee-for-service. There are disincentives to be working in a walk-in clinic in fee-for-service environment. So we're seeing a real change in the models of care in Ontario. And I thought what I would do is talk a little bit about the models that we've developed in Southern Ontario, the family health teams, and try and put it into context of what is a solution that's worked for us, which does not mean that it's exportable to Manitoba or British Columbia, but I think there's some principles that I will try to highlight as I go along. This is our Department of Family Medicine building in Hamilton, which opened a couple of years ago. Our department actually owns about a third of this building, and uniquely, we have one of our 2 family practice teaching units for Hamilton in this building. This is actually in downtown. It's about maybe a quarter of a kilometer away from the highest needs population in Hamilton. So just to say, we purposefully built this in our high needs area. So we run 1 family practice unit here in this clinic. We have about 30 residents. We care for around 17,000 patients. On the top floor is our administration, family medicine administration, on half of it, and the other half is public health. And so the medical officer of health, her office is physically adjacent to mine on the top floor, which has huge implications in terms of responding to community need and community challenges and issues. Our research department is on the 5th floor, and we have somewhere in the region of 25, 30 researchers who are based in that area. So the McMaster Family Health Team model, which is similar to the Family Health Team model in Ontario, I think we are lucky that we've been able to do some tweaks, but we're team-based. So even though there's 17,020 some odd family physicians at the downtown site, we divide it into 4 smaller teams. Every patient has their own family doctor. And if you go to RateMD and you Google David Price, not Morgan Price, but David Price, you'll find 2 evaluations of me in RateMD, and one of them is, I understand that Dr. Price is a great guy. I've never met him, but I really like the team that he works with. And I don't know who that is, but it's one of my patients. So everybody is assigned to a family doctor, and I get all of my patients' results in Oscar, and I know who they are, but they may see the nurse practitioner or one of my colleagues or one of the residents. But at least they are assigned, so when they go into hospital, they always identify that David Price is my family doc. We do have booked evenings appointments. Every single physician does work an evening every 2 weeks, give or take. We do a Saturday, Sunday on-call, whereby the office line is open at 9 a.m. The physician shows up at 10 with a resident, and you're booked. So as a patient, you know that your appointment's at 10 o'clock or 10:15 or 10:20 or whatever it is. Your wait is minimal, but it's for more urgent stuff on the weekend. We'll see anywhere from 1 or 2 patients to the most I think we've ever seen is something like 45 in one day. and we do an annual awards, and you either get the Horseshoe Up Your Derriere Award, which is for the least number of patients, or you get a bottle of wine for the one who sees the most patients on the day. There is a 24-hour on-call physician. So if you as a patient phone up, you will always get put through to a physician. I talked a little bit about the groups. And I think uniquely, we think of our group as providing prenatal to palliative care care across the spectrum. None of us are doing prenatal care, deliveries, palliative care, sports medicine. I mean, no one of us anymore does everything, but as a group, we absolutely do everything. We have visiting specialists, so we have pediatricians, psychiatrists, physiatrists, geriatricians, internists. I think I said pediatricians. Anyway, a whole gamut of specialists that come to our clinic, and it's cost effective for them. They make money. They like it because it's efficient for them. They have the chart right there. They often have the quick quarter consultation with the family doc or the nurse practitioner or whoever is the responsible person. Patients, of course, love it. Parking in our facility is $3 an hour, and in the hospital it's $15 an hour, and you have to wait for 2 hours to see the specialist. So, I mean, it's you're always, I've spent more time in hospital than I care to think. So it's the kind of system we hope whereby we're caring for a population of patients and providing a whole basket of services for our patients. And we're able to do it in a really nice environment, and that is, I think it's state-of-the-art, it's fully electronic, etc. And I thought it's worth just sharing the dollars with you. So the clinical revenue for the physician group is about $8.5 million. We do receive money from the government for our allied health professionals, which is about $4 million. So it's about a $13 million a year clinical operation for those 35,000, 36,000 registered patients. Okay, so hold that thought in your mind. I want to emphasize that it is not an individual. When we look at these results that I'm about to share with you, it is a team. It is a group of individuals, from administrators to clinicians, and it's a team base. So this is in the lobby of our building, which is kind of neat when we're able to have celebrations. So what are our outcomes? Briefly, we have a lower emergency room visit rate, both for our Hamilton patients compared to Hamilton and for the population in Ontario. So our ER visit rates are low, and we know that ER visits in Canada have been going up year over year, decade over decade over the last 25 years. Our readmission rates are lower than the provincial average for our cohort of patients. And remember, I said that we haven't cherry-picked the well patients. We are in an inner city and have high numbers of immigrants and refugees. We do receive quality reports on a monthly basis, and we look at our outcomes, whether that's our diabetes care, whether that's our COPD, et cetera. So we're able to track our quality outcomes, and we'll stand up against anybody. And we've also been able to look at our total healthcare costs for our patients. So what this is every single dollar that is spent by the government for a patient, whether that's to see a primary care specialist, to see a specialist for their hospitalizations, for anything that OHIP pays for. Remember I said that we got money from the allied health professional, for the allied health professionals? We factored that in, and we are still about 10 or 15% lower than the average Ontario cost, which what that tells us is you can invest in this kind of model, you can do team-based care, and you can have excellent outcomes, and you can reduce your costs. the stat that I love sharing with the ministry is that if the rest of Hamilton had the same emergency room admission rate that we have in our practice, we would close one of the 4 emergency rooms in Hamilton. And that's a huge saving. Now we're talking not just tens, but 20s or $30 million of savings. And so it's probably worth thinking about, and that's where I think we've been able to convince our ministry to move towards, is doubling down on the investment in team-based primary care. And the team consists of nurse practitioners, social workers, pharmacists, dietitians, system navigators, the whole gamut of healthcare professionals working together as a team, having huddles on a regular basis because I don't need to see 50 patients a day to make ends meet. I have a capitated amount per patient per year, and I get an extra little bit every time I see a patient. And so that works. Now, I've made it a bit Pollyannish. It's not quite as good as I'm making it out to be, and there's some challenges. If you want to ask me what the challenges are, I'm happy to share those with you. I'll allude to them a little bit. I think partly as a result of some of the work that we were doing at McMaster, I was asked to chair the expert advisory panel for Ontario in 2014-16, and we were able to get a group of primary care experts together around a table. And it's interesting, Ontario tried this in about 2010, and they had the president of the Nurses Association, the president of the Ontario Medical Association, the president of this, the head of that. And that group got in a room, and it was a complete bun fight, and it was all about turf, right? Everybody was protecting his or her own turf in their profession. I think what we did well and what we did differently in this was we got acknowledged leaders in the field who were interested in representing the healthcare. Yeah, they were family physicians, they were primary care providers, they were nurse practitioners, but they weren't there representing an association. They were trying to figure out what would work for them. When I sat down with the deputy minister and the assistant deputy minister, we came up with 4 key policy questions for our group that we should tackle. One of them was regular provider. How can we ensure that all Ontarians are attached to a regular primary care provider? Can we ensure after-hours access? Can we ensure interprofessional care? And how do we integrate our primary care into public health and community health and into the larger hospital and healthcare system? We created something we call patient care groups. And I should acknowledge that this was a group effort again. It's never the work of one person, and particularly acknowledge Brian Golden, who's a professor at the Rotman School of Management. Hugely influential in thinking about how we did with this. Our big thing was creating equity, not equality, understanding that folks that are in inner cities need a bigger lift than somebody who lives in Shaughnessy, right? And we need to be focusing on that. And I didn't make that slide up. I stole it from the internet, and I can't find who did it. It's not attributable. And we tried to create and understand the model of primary care. So primary care, just so we're all on the same model here, or same definition from my perspective, primary care is what we do in our office, providing direct primary care for our patients. Primary health care is what we provide in the community alongside. So whether that's the social housing, whether that's Meals on Wheels, whether that's a visiting nurse, whatever it is, that's what we consider to be primary health care in this model. And so we created what we would call a population-based primary health care system. And what was key, the key principles are local governance, and I've written physician leadership in quotes purposefully, because it's not about a doctor being in charge of this. It's about a doctor providing leadership around the care. It doesn't mean that they are the leader of the group. I think a family physician is probably the linchpin of the care, but they are not necessarily the leaders. And we have leaders in our group that are well, we have a physiotherapist who's a leader, is the lead for one of our groups, a nurse practitioner who's the lead, and in fact, we have a system navigator who has a social work background who is the lead in our primary care group. We talked about accountability, and one of the challenges that we've had with our team-based model and the capitated is a lack of physician accountability, and we'll be upfront about that, and we can go into the details. But we felt that if you have peer-to-peer accountability and peer to your group and your community, that leads to a better accountability. We always think in medicine about my patients in my practice, right? We don't think about my patients within the context of our community and in our system. We looked at quality and outcomes, and also there's a real need for public health information to help us understand where to put our priorities and where to invest in it. I mean, it's really obvious in the downtown east side, but you've got pockets all over the GVRD where there are needy and individuals at higher need. If we can identify them, maybe we can put the resources in upstream as opposed to responding once they end up having challenges. That work has led to the Patients First legislation, and I won't. These slides, you certainly are welcome to them, but the Patients First legislation was passed by the provincial government, utilizing some of the work that we had done in this, but really talking about more timely and effective primary care and integrating into a healthcare system. So Patients First was passed 2015 or 16, I can't remember now. And I think that then, sort of to sum it all up, says who should be leading this in Canada? Where does this change come from? And I can't think of any better group than community practitioners in partnership with university academia to help lead this. I think that's what we've seen in Ontario. That's what we seem to be seeing in Nova Scotia and in other jurisdictions, is that it's our responsibility collectively to drive this change. Because as academics and as community physicians, we know that our system isn't working. And it hasn't been working for more than a decade. And we keep being satisfied with coming in 12th or 15th in the world. It wasn't acceptable in our Olympic program. We created Own the Podium, but we seem to be really comfortable with being 11th or 12th. And we talk about it, but our politicians, they haven't had a fire lit under their proverbial to help us make those changes. And I think that's partly our responsibility in collaboration with our community partners, because they're experiencing it. They're equally frustrated out in the communities with the lack of resources and the responsiveness. And I think if we can move that, we can move it towards an accountable team-based care. We need to modernize the remuneration system. There's no question. We need to move away from the fee-for-service treadmill. We need to be thinking about population health, which is integrated into the community with both public health and secondary and tertiary care. I've only been here 24 hours, and I've heard about all kinds of really neat, innovative solutions and things that are happening in British Columbia and in Vancouver. But of course, like everything, we're a nation of pilots, right? And there's pilot stuff that's happening everywhere, and we're not scaling it, and we're not moving towards it. And so I hope what you'll think about is that it's not a huge shift for us to move our primary care system from where it is to where it could be a high-performing system. You remember that first picture that I took of the steel mills? I'm standing on the bridge looking. All I've done is turn 180 degrees. And if I only showed you or an international audience this picture of Hamilton, you'd have a completely different idea. So I'll stop there and look forward to any discussions or questions. Thanks. Yes, sir. If I give you, do you have a mic there? Yes. There you go. Yeah, that's a fair question and a fair observation. So I think it's probably fair to say that in our hospital systems, if we did not have administrators, it would be total chaos. We need somebody to help organize so that the supplies show up in the OR, that there's scheduling that happens to make sure that the nurses show up, that the patients are coordinated and organized, and it has to be done in an efficient and appropriate manner. And we can argue whether or not we're getting the best value from our administration in hospitals, but I think there's no question that that has to happen. And we are finally, I think, moving, certainly in Ontario, towards developing a cadre, a class, however you want to put it, of primary care administrators who understand how to coordinate and organize a community-based primary care system or primary health care system. It's probably not possible for the doctor to run his or her office anymore and be efficient and coordinate all of the staff. I showed you the value of our clinics. It's $13 million. There's no way that I have the skill set to manage the complex human resources. Our staff are all unionized to do the acquisition of the medical supplies, et cetera. So I think there's no question that there has to be some sort of coordination at a primary care level. You can argue that we have too much or too little, but from my perspective, there needs to be that group that understands and helps coordinate it. Is it led by the primary care administrators? Probably not. But I don't think it equally needs to be led by physicians. It needs to be community-led and understood as in responding to the needs. Please. So maybe I can just...
Hi, it's Diamond. We can't actually hear any of the question.
Okay, so I'll just summarize it. And the concern was that...
presentation to us 2 years ago was comparing the evidence of the family health teams in Ontario and that with the other primary care models, various FIGs,
Yep.
fee-for-service, is that there was not evidence that the family health teams, in fact, looked after more complex patients, and therefore the model was
So I know Rick's
questioned.
work well, and I work with Rick quite a bit. So I'll have two comments about Rick's conclusions. The first is that he works with ISIS, which is all based on diagnoses that are entered by family physicians as they do billing. And we all know what's the quickest way to get out of the chart is to throw any old diagnosis down so that you can move on to the next basis. So that means that challenges right away the data that you're using from that perspective. The other thing is that Rick is quick to acknowledge this, is that was early evaluation data when these teams were first formed. It was in the first 2 years of the formation of the bulk of these teams. There's no question that when you start something early on, you're learning how to be together. You know, you throw a bunch of hockey players on a team together, you don't expect outstanding outcomes in the first week or two. It takes time to develop it, and I think that's where the evidence is dramatic now, and it's evolving as we accumulate the evidence to say that these outcomes are good. There's no question when you look at something like what we're able to do at McMaster, it's in a special environment, a little bit different, but we are dealing with real patients in a real environment and in a cost-effective way because, believe me, the university doesn't give me an extra penny to manage our clinic, so we have to do that. So I think the evidence is coming, and absolutely would say that whatever system that you end up developing in BC has to be done with evidence being accumulated and gathered on a regular, ongoing basis so that you can course correct. The challenge always is don't make a system whereby you're going to do a pilot in 4 places and in 4 years we'll evaluate it and then we'll think about it. Figure out what the model is that you want to move towards, and boy, there's a ton of international evidence right now. There's lots of evidence out there to say what might work. Figure out, contextualize it for British Columbia, because what works in New York isn't going to work here. And what worked in Hamilton ain't going to work here either. So what is the BC unique secret sauce that's going to work? And of course, it's not what's going to work in the Lower Mainland. It's very different than what's going to work in Prince Rupert. So it needs to be contextualized and then move forward. But I guess what I would leave you with is what you're doing now and what we are doing now in Ontario and Canada writ large isn't showing the evidence. All the evidence is pointing out that it's not working. So it needs to evolve because we need to keep up with it. How do we do that intelligently?
David, I'm just going to go online to see if anybody has a question on the phone or on any of the other remote sites. And I know we've got a couple of questions here, so I'll pass it over to Martin. Just got a few minutes left.
Yeah, just quickly, I mean, I'm a huge advocate of teams because the evidence is quite clear, but the rural aspect here is, and you just touched on it briefly, you know, the publicity is emergency rooms closing because there isn't the doctors available in rural areas, no obstetrics, people traveling long distances. Is there any evidence coming out of the work in Ontario and maybe other places looking at teams in rural areas and how we might develop those?
Yeah, I think there is some good evidence, and I'll use one specific example that comes to top of mind, and that's Marathon. So Sarah Newbury, who was the president of the Canadian College not that long ago and who comes actually from Smithers and Terrace area, and Burns Lake, I think, is exactly. Hazelton, she's from Hazelton originally. Their model in Marathon, which is an isolated rural community, it's 2.5 hours drive north of Thunder Bay, so you can't fly in there most times of the year. They provide everything from birth to palliative care. Their outcomes are pretty darn amazing in terms of the quality of care. They have zero problem recruiting young family physicians to their community. Why? Because it's a coordinated, integrated community response with mentorship of their younger family doctors. They have instant access to the older, more mature, experienced family doctors. They've figured it out what works for their community. 25 years ago, that was the opposite. It was headline news in Canada how badly off they were in Marathon, and they've completely turned it around. So I think there's a number of examples like that across that you could draw on.
David, thank you for a provocative and interesting talk. You've kind of answered one of my questions around, are the young grads embracing it, and you kind of just addressed that a little bit. Dermot and I in particular, and other members of our team, have been really trying to engage our government around really revisiting models of care here. And we've got various examples in the primary care situation, but it's not just primary care. I guess the question that I may get more from you offline on this, but how are you able to get the government convinced to what in often cases is an upfront investment for the downstream cost savings and improved health care? What was the thing that made the difference to make government do that? And if you have time, the second question is, how did you convince the physician associations that the old school fee-for-service model might not be the one-size-fits-all anymore?
So the answer to the first question is obviously complex, but the fundamental issue was that it was a crisis. Family physician or family medicine and family practice in Ontario in the early 2000s were in crisis mode. I think Ontario was 1.8 million Ontarians that did not have a family doctor and weren't accessing. Costs were spiraling. Emergency room visits were going up. It was quite clear that you needed to have a multifaceted approach. I was part of the negotiations with the OMA at that time, and there was a carrot. There's no question. And at that time, family physicians, we had a net migration of family physicians out of Ontario, either to the west, to the States. We had a very poor uptake of 25-30% of our medical students were choosing family medicine. It was a real crisis, and so it was a multifactorial approach, and the government, frankly, put some money into it. The challenge right now is for example, in Nova Scotia. Nova Scotia has a family physician shortage, and the solution that's being promoted is let's increase the amount of money that we're paying family doctors. I have no problem with increasing the amount of money that we're paying family doctors, but it needs to be done intelligently that drives the kind of care that's needed. And that, I think, was the OMA, and the OMA had a family physician as president at the time, and the chief negotiator, was a very enlightened family physician who looked at it and said, you know what, I'm running on a treadmill and this isn't going to work long term, and my patients are complex. I've got my patient population is aging. I can't do this by myself. And I think for him, it was this was part of the solution for his particular thing, and that made a big difference.
Well, David, thank you. It's just exactly 5 o'clock.